To truly understand the femoral nerve block, it is advisable to study the appropriate essential anatomy as outlined in the Primer of Regional Anesthesia Anatomy before studying this block. The single injection femoral nerve block alone or in combination with other blocks such as the sciatic nerve block is indicated for surgery to the anterior part of the knee, femur, medial tibia, first toe, and medial side of the foot. It is essential to study the osteotomes, dermatomes, and neurotomes of the lower limb to understand the extent of this block. The femoral nerve originates from the second, third, and fourth lumbar root, and the bones of the L2, L3, and L4 osteotomes will be covered if this nerve is blocked. Note that this starts with the femur and continues down to the medial aspect of the tibia and medial side of the foot. Included in this block are the skin area supplied by L2, L3, and L4 dermatomes. Notice again that this goes down all the way to the big toe area and the medial aspect of the foot. The single injection femoral nerve block usually does not involve the area innervated by the lateral cutaneous nerve of the thigh on the lateral side of the thigh, nor does it usually involve the medial area of the thigh innervated by the obturator nerve. The obturator nerve originates from the anterior rami of L2, L3, and L4 and gives off branches to the hip joint and the posterior aspects of the knee joint. A pure femoral nerve block will involve the areas shown in this illustration, which include the anterior aspect of the thigh, the medial aspect of the lower leg via the saphenous nerve, and via the same nerve, the medial aspect of the foot. The single injection femoral nerve block is therefore almost always combined with a sciatic nerve block for knee, ankle, and foot surgery. It is also used for pain expected to be of relatively short duration, such as following medial meniscectomy of the knee. For pain of longer duration, such as after anterior cruciate ligament repair or total knee replacement, a continuous nerve block is optimal. Almost all local anesthetic agents in various volumes, concentrations, and combinations have been used for this block. The preference of this author is to use 15 to 40 milliliters of ropivacaine 0.5 to 0.75% or bupivacaine 0.5%. Ropivacaine 0.5% or bupivacaine 0.5% plus 0.3 milligrams of buprenorphine will make this block last up to 3 times longer, but if a long-acting block is required, it is better to place a continuous femoral nerve block. It is, however, essential to place the needle deep to both the fascia lata and fascia iliaca to be successful with femoral nerve block. The patient is positioned supine and the femoral artery is palpated and marked. The point of needle entry is approximately 1 sun, the width of the patient's thumb, lateral to the artery, and 1 sun caudat to the inguinal crease as marked in this demonstration. After disinfecting the skin with an appropriate solution, the skin and subcutaneous tissue is anesthetized. The stimulating needle enters the skin at a slight cephalad angle, and 2 clear pops can usually be felt as the fascia lata and fascia iliaca are penetrated. The nerve stimulator is now typically set at an output of 1 to 2 milliamps, a frequency of 2 Hz, and a pulse width of 100 to 300 microseconds. The nerve to the sartorius muscle is often encountered, and this should not be confused with femoral nerve stimulation. Slight adjustment of the needle will bring it in contact with the femoral nerve with resulting clear cephalad movements of the patella due to quadriceps muscle contractions. The nerve stimulator is now turned down to 0.3 to 0.5 milliamps, and brisk contractions of the quadriceps muscle must still be present. Injection of local anesthetic agent or any other conducting fluid, such as normal saline, as in this case, will cause the muscle twitches to stop immediately. This is a positive Raj test, which gives further assurance that the block will be successful. This recording, from another angle, shows the sartorius muscle twitches followed by the quadriceps muscle twitches due to femoral nerve stimulation.